So I think now it's time to go up with
Start
your
the meeting.
presentation. Yeah, so please, Jiafang, thank you, please.
Okay. Good morning, good evening, and good night, everyone from all over the world. So thank you for Bao Yunzhou to arrange this great event. And today we are happy to invite Dr. Zhu Jun from Singapore to present the obstructive sleep apnea introduction, evaluation, and treatment. We also have esteemed faculty as our panelists today. We have Professor Lin Zhenhui from Chang Gung Memorial Hospital and also Bo Fang from Chang Gung Memorial Hospital, Taiwan, to help us with today's talk. So I'm Laura Chen from Chang Gung Memorial Hospital, the 6th-year resident. I will moderate the talk today. And Dr. Zhu Jun graduated from University of Edinburgh and completed her otolaryngology residency training in Singapore. She obtained further professional qualification of fellowship of the Royal College of Surgeons in the otolaryngology with the Royal College of Surgeons of Edinburgh. And then she has lots of interest in the subspecialty of the sleep disorders breathing. She tried to help the patient with the symptoms of the obstructive sleep apnea to reduce the adverse sequel. And she's in the constant pursuit to help patients to improve their sleep-related quality of life. And also she has strong enthusiasm in the patients and the junior doctors' education. So she believes that empower patients by enhancing their understanding of their own conditions like the sleep apneas and equip patients with strategy to manage their conditions. She is also passionate about helping medical students and the residents helping developing their potentials and the careers. She was awarded as the NHG at US Medicine Junior Doctor Teaching Award in 2016 as the recognition of her accomplishment in the undergraduate education. So we are very happy to have Zhu Jun for us today. And now time's yours. Thanks.
All right. Thanks a lot, Laura. And it's an honor and pleasure to be back here at this platform. And thanks very much to Dr. Zhou Bangyu for inviting me. I'm just going to start off with these slides, which unfortunately now doesn't run. Okay, yeah, so my name is Chu Qin. I'm an ENT surgeon by training. My first fellowship is in Singapore General Hospital under Professor To Sung Ta, and I also did Chang Gung Memorial Hospital in Taiwan back in 2020. I am the chief of sleep surgery service at Sengkang General Hospital. It's quite easy to be the chief when you're the only person doing sleep surgery there. But what I'm quite proud of is that myself and a couple of my colleagues, we are the founder of our department. We were there when our hospital was being built. Our hospital actually opened officially in 2018, and this is actually our very first ward round, first day of opening. Okay. My sleep unit team, actually, we were lucky enough to be awarded a fellowship, scholarship by the Ministry of Health Singapore to go learn in Chang Gung Memorial Hospital with the objective of setting up a sleep service. And this consists of our sleep medicine colleague, who's a respiratory physician, myself doing sleep surgery. We have orthodontist, we have OT nurse, and we also have a sleep technologist who came with us. And this was actually taken in one of the restaurants near Chang Gung Memorial Hospital, the Linko branch. The decision for fellowship at Chang Gung Craniofacial Center was because we realized within ENT, just doing soft tissue surgery does have a lot of setbacks, and it was quite important for us to actually learn from strengths of other specialty and integrate as well as collaborate to form the best care for sleep apnea patients. And Chang Gung Memorial Hospital was the natural choice because it is the established center for orthodontic surgery with a very large volume. And I had a very good time under the tutorship of my fellowship director, Professor Clement Lin, who truly is a master of an art with his training where he actually underwent sleep medicine training with Professor Gilminor all the way in Stanford. And he's got really high volume in OGS surgery. Such that, when you go to him, you actually see very well thought out sequences and steps when he executes the surgery, which is always backed by evidence and rational to achieve the best outcome for the patients. I also had the luck of actually following Dr. Yao, who is a fantastic surgical teacher. He breaks it down into simple steps for you. So bear in mind, I come from an ENT background. Unlike most of you, I think a lot of you would have had some orthodontic surgery experiences before going to Chang Gung. Yeah, so this was, you know, Dr. Yao was amazing in terms of his surgical execution, and he's got a very keen eye of aesthetics. He's quite passionate and resourceful. He always shared with us a lot of his landmark papers, his presentation, and he's great for learning computer-assisted surgical simulation as well. He's just got a very systematic set. This is his questionnaire where he then transfers it into his planning. I was also very lucky to have spent some time with Dr. Chen, who's highly specialized in cleft lip and palate care. You know, there was a lot of hands-on experience when I was in her OT with very high-yield discussions and demonstration on surgery techniques. She tells you what is safe to execute, and she tells you, you know, how to progress, and, you know, gave me a lot of advice in terms of how to learn and grow my service as well. Not forgetting, we had a fantastic year in my year because we had fellows from all over the world who were close and, you know, helping each other out. We had Elki from Indonesia, myself, Imber, Ivy, Maria, and Kishore, as well as Nisha. We had, I mean, this was during COVID time. We still, I mean, Taiwan had very control back then, and this was us out kayaking. We did paragliding and all as well. So, I mean, if you're thinking of fellowship at Taiwan, I think it's a fantastic place to be in. So I actually felt severely underqualified to actually give this talk, but at the same time, when Dr. Cho asked me, I felt like I owe it to Chang Gung Hospital and the team who treated me with a lot of kindness and generosity. So what I thought I'll do is I will focus on most of the things I know, and I will share a bit of what I learned in Chang Gung Hospital in terms of OSA and orthodontic surgery. So sleep apnea, the definition, it is defined as the repetitive upper airway collapse during sleep, resulting in intermittent hypoxia as well as sleep fragmentation. Now, these 2 points are important to remember because this is how it causes all the other health problems like the hypertension, arrhythmia, heart problem, and so on. The true definition as per the International Classification of Sleep Disorder 3 is actually using the RDI. So using the respiratory disturbance index of 5 or more with symptoms. So if your RDI is low, you gotta have some symptoms. Or if you have RDI of 15 or more without symptoms. The symptoms are said, those include daytime tiredness, any gasping and choking in sleep, any snoring or witness apnea, or if there's any presence of any comorbidities which are associated with sleep apnea, such as hypertension, ischemic heart disease, stroke, atrial fibrillation, and type 2 diabetes. Now, it is important to understand a bit of a pathophysiology of sleep apnea. So when you sleep, your muscles generally relax, and this kind of leads to airway collapse, and airway collapse leads to hypoxia. When you have hypoxia, the body naturally responds by increasing the respiratory effort to make you breathe again, so you can, you know, get your oxygen level back up again. But this actually leads to arousal, mini arousals that patients don't remember, but nevertheless actually affects their sleep because it causes sleep fragmentation. And this leads to the very common complaint where sleep apnea patients have, where they tell you they're very tired during the day, no matter how many hours they sleep. That's because their quality of sleep is actually terrible. And when they actually leads to sympathetic activation. This sympathetic activation is what leads to all the you know, comorbidities or consequences related to sleep apnea, like the cardiovascular problems, neurological problems like stroke, any metabolic problems like diabetes and obesity, even eye problems like glaucoma and erectile dysfunction and so on. And it is also important to understand that, you know, sleep apnea does have different phenotypes. One that is most commonly talked about is the PALM, P-A-L-M. P stands for the P crit, A stands for arousal threshold, L stands for loop gain, as well as M is muscle responsiveness. This was actually published by Eckert and his colleagues initially back in, I think, in about 2014 or so. This is important to understand because, you know, in essence, when we deal with the P crit, the critical pressure of collapse of the upper airway, most of the time as surgeons, we are only dealing with at-risk anatomy. For ENT, a lot of times we deal with mostly soft tissue hypertrophies like large tonsils, your low palate, having large tongue. And for most orthodontic surgeons, we deal mainly with skeletal deficiencies, obesity. But why surgery results can still be unpredictable, because there are other physiological reasons, physiological phenotypes of which patients might have these underlying problems and might not respond so well to surgery. For instance, some patients can have actually very low arousal threshold, meaning they actually wake up to very little or simple respiratory disturbances. The problem with waking up too often is that they don't get into a deep sleep enough to recruit upper airway dilator muscles to keep the airway dilator muscles open, to keep the airway open. And some patients actually have a high loop gain issues where, the way I think of it in a very simplistic manner is that these patients overreact. So for instance, some patients, when we sleep, we breathe in and out, breathe in and out. And then these patients, let's say if it's that there's a short hypoxia, so they snore, they go into apneic episode, there's a small hypoxia, they react by overbreathing, hyperventilating. But as a result of hyperventilating, then their oxygen, their carbon dioxide levels, they go into hypocarbia, carbon dioxide levels actually go down, and then they go into another round of not breathing. So this whole disturbance of their breathing actually makes it very unstable and makes the airway more collapsible. And there's also a group of patients where you can see in this picture where, this is trying to show you that when the airway pressure is negative, in normal patients, this EMG of the muscle should actually show mounting response, where some patients, the muscles just don't respond, resulting in a collapse of airway. So these are the physiological reasons that contribute to sleep apnea are actually medically treatable, but it in part explains to us, why sometimes our surgical results might not be that fully predictable. Okay. In terms of OSA evaluation, starting with history, just one slide telling you the questions I tend to ask in my clinic. We screen through the nighttime symptoms, like we ask if there are any snoring, any witnessed apnea, any gasping or choking, any night awakening, nocturia, or any difficulty falling asleep. And daytime sleep symptoms are important to exclude as well, like daytime sleepiness, unrefreshed sleep, having any morning headache, any dry throat or dry mouth in the morning. I tend to ask about contributing factors as well. For instance, any recent weight gain, any nasal condition that actually lead to nasal obstruction, because this can actually contribute to upper airway narrowing as well. I tend to ask about sleep hygiene, what time they wake up and sleep, because some will come to you and say, I'm very tired all the time, but they only sleep about 4 to 5 hours every night. And that tells you that is on top of sleep apnea, this is another component, getting them to sleep sufficient hour is also important to manage. Patients with shift work can have very disruptive sign of how tired they are at times. So usually 1 or 2 is a reasonable amount. And past medical history wise, I tend to ask about anything related to sleep apnea. Social history, I tend to ask about, has this sleep apnea or this snoring or tiredness affected your work, or have you gotten into any accident because you dozed off on driving? And family history is actually important to establish as well, because sleep apnea can run in the family. In terms of physical examination, I will tend to check their BMI and the skeletal pattern. At a very simple screening that we do in clinic is that we put them on the Frankfurt horizontal line. We draw a line down from the nasion, and if the line is, if the chin, the pogonian is actually behind the line, you take it as a retrognathia. And we don't really screen for neck circumference, but this is something that has been published. For male, if it's more than 43 centimeters, or for female more than 40 centimeters, the risk of sleep apnea is a little bit higher. And this is a picture from my mentor's paper in 2011. The significance of checking all this, retrognathia is that you can potentially perform maxillomandibular advancement surgery that can enlarge the airway. As you can see, this patient is a class 2 skeletal patient with a pink color part being the airway, and you can see post-surgery with all this nails and pins is that the airway is actually enlarged. I realize it's important to actually let people know about the soft tissue part as well, because if you're an orthodontic surgeon, it's also important to have some awareness of what are the other causes of obstruction, so you can actually provide the patient with a more comprehensive treatment plan as well. So tonsil size is important to establish. There's 0, 1, 2, 3, 4. 0 is the tonsils will remove. 1 is very small. 2 is it peeps out a bit. 3 is it goes beyond the pillar, and 4 is kissing. So sleep apnea patients, sometimes you can see, usually grade 3 or grade 4, this sort of tonsillar hypertrophy. Tongue scalloping is something like that, where you see, imprints of the teeth on the tongue. This is trying to tell you that, hey, the tongue is quite large for the oral cavity that it has. Some patients can have high arch narrow palate, which I'll show you some of the pictures, and palate position can be low, and I tend to check for long uvula. Friedman tongue position is also another name you can use for it. It's the modified Mallampati, which I explain a little bit in the next slide. So Friedman tongue position and modified Mallampati is a staging system that sleep surgeons usually use to grade the tongue position in relation to the tonsil, the uvula, soft palate, and hard palate. Here you have grade 1, where the tongue is actually not that big, and when you can see the whole tonsil, the whole soft uvula, soft palate, and hard palate. And grade 2 is where, you only see the tonsil pillars partially. Grade 3 is you don't see the tonsils at all. You could still see the soft palate. And grade 4, you can see the tongue is sufficiently large, and you can only see the hard palate. This Friedman tongue position or modified Mallampati gives you an indication of the degree of tongue-based obstruction. And the higher the Friedman tongue positions grading, so like 3 and 4, there has been paper that showed that it's associated with narrower posterior airway space, which is bad news for sleep apnea patients, because if you have narrow airway space, they're more liable to collapse. And if you look at high narrow arch palate, here showing you one that's a normal palate, and you can see this one is almost like a bit of dome-like, very narrow palate. This signifies transverse maxilla deficiency, and it's usually associated with nasal resistance and posterior tongue displacement. Again, posterior tongue displacement narrows the posterior airway space. So OSA patients tend to have a higher narrow palate, and how this tend to happen, from childhood to growth, is that most of these patients will have some degree of nasal obstruction from like allergic rhinitis or adenoid hypertrophy that leads to mouth breathing. When you mouth breathe, right, your tongue goes in a very poor posture. It doesn't stick up against the hard palate, and when there's no contact between the tongue and hard palate, it just reduces the horizontal expansion of the maxillary arch, leading to transverse maxillary deficiency. The significance of this high arch palate is that, you can consider if the kid is still young, usually before 14 or so, 14 or 15, you can actually add on expansions. If it's adult, sometimes you may have to perform an osteotomy and then add on the expansion in something called the distraction osteogenesis maxillary expansion. Oops, sorry. So, palate position is another one. People always tell you that, hey, sleep apnea patients have low-lying palate. What exactly does that mean? So it's hard to gauge. So we use the maxillary molars as well as the mandibular molars as a bit of a guide. So if you draw a line across the mandibular occlusal plane and the maxillary occlusal plane, the palate, the base of the uvula should be above the mid-occlusal plane. Here I'm showing you a picture of an OSA patient. You can see the base of the uvula is actually at the mandibular occlusal plane. So we call this low-lying palate. And this is the same patient post-surgery, where you can see it's reconstructed to above the mid-occlusal plane. The significance of low palate, you can consider palatal surgery like uvular palatoplasty. You can do some palatal advancement. Sometimes you can put some heat with coagulation-assisted uvular palatoplasty. As ENT surgeons, we have the benefit of scope. So these are things we look for: any, deviated nasal septum or large turbinates inside the nose, any nasal polyps, adenoid hypertrophy. Here showing you one this is normal. This is a grade 1, this is grade 2, and grade 3, where it's actually blocking the nasal airway. We don't really do molars nowadays because it doesn't really predict surgical outcome that well, but we do take note of the retropalatal space, retroglossal space, the lingual tonsil as well, which I'm going to show you some pictures. So some pictures of normal versus sleep apnea patient. You can see, this is nice, large oral cavity, Friedman tongue position 1, whereas this, you can see large tonsils. And here you can see modified Mallampati or Friedman tongue position 4 versus that of 1. You can see the nasal cavity. This is showing you normal nasal cavity, where from the front I can actually see the postnasal space, whereas this one is actually a swollen one. And this is trying to show you a deviated nasal septum to the left. And retropalatal space in normal patients compared to OSA patients, you can see OSA patients tend to be narrower. And some patients can have lingual tonsil hypertrophy, big ones here, which sometimes as ENT surgeon, we remove them with the Da Vinci robot. Some of the tongue obstruction is not from lingual tonsil, they're from muscular tongue. You can see the tissue is different, and this is muscular tongue, and it's actually causing obstruction. You can barely see the vocal cords at all. And sometimes it's the epiglottis that is actually too long. And one that we find very difficult to treat with soft tissue surgery is where you have lateral pharyngeal wall collapse. You can see, normal airway should maintain, and this patient, it just sucks in like that. Because for soft tissue surgery, there's very little that you can resect, or there's very little you can do to improve the tension. This is where, MMA surgery can become very useful. Okay, in terms of investigation, it's important to know that there are different levels of sleep study. There's level 1, 2, 3, 4, 1 being the most comprehensive and the gold standard, the ones that you usually have in hospital, where you have at least 7 channels and you have a sleep technician to actually monitor it. Level 2 is a bit like 1, except that it's unattended by a sleep technician. Level 3 is less channels, about 4 channels, but you got to have a bit of ECG, heart rate. Some are measuring the respiratory effort or the airflow. And level 4 is a minimum of 3 channels, some at least measuring oxygen saturation. I find it easier to divide it into the one you do in hospital and the one that is portable, meaning you can either do it at home or anywhere else. So, there's pros and cons between hospital and home sleep study. So level 1 is your hospital sleep study is the gold standard. If you have any complicated patients, you got to do it in hospital because they simply have more parameters they measure, it's more accurate, and you have the technician to troubleshoot. But the problem is it's actually quite expensive, it's labor intensive, it's very long wait time. I'll show you some papers. And sometimes you've got the first night effect where the patients can't sleep and you can't get enough recording because they're in an unfamiliar environment. Home sleep study is generally cheaper. In a hospital, you can do it the same day after surgeon. It's more readily available and it can be done in the comforts of a patient's own home, which arguably is more reflective of the patient's native sleep condition. Of course, it does have less parameters, and sometimes it can underestimate the AHI. And if the results are doubtful, you may have to repeat a hospital sleep study, which kind of increases the cost for the patient. So just showing you an example of hospital sleep study versus this is the home sleep study that we use in my hospital. So, wait time for sleep study is rampant across the world. This is a paper from Canada. It tells you the wait time for therapy is actually 11 months because they just can't get a date for sleep lab. In Singapore, when I did this last survey, the wait time is anything from 2 to 11 months. And a lot of people find it uncomfortable to use home sleep study because they worry about the accuracy. But truth is, current published evidence there's already meta-analysis that shows that home sleep study does have high correlation compared to the polysomnography. And in fact, the American Academy of Sleep Medicine back in 2017 already published this paper that endorses the use of home sleep apnea testing, but only in uncomplicated adult patients where you already assess to have increased risk of moderate to severe sleep apnea. So patient selection is the key. You can use it, but you need to select your patients well. And this is from my own study where we already showed that using home sleep study, we were able to reduce the time to treatment. In the yellow box is our patients who were given polysomnography, and the blue box is the ones who had WatchPad, which is our home sleep study. The time to treatment is actually 126 days for PSG, and only about 1 month if you actually have the home sleep study done. Earlier treatment arguably is important for sleep apnea because you can hopefully deal with and prevent any heart or brain consequences associated with sleep apnea. So in terms of sleep apnea treatment, The first thing to understand is, as we mentioned, sleep apnea does have a very heterogeneous pathophysiology. As mentioned, we have the at-risk upper airway anatomy, generally divided into soft tissue, any skeletal problem, or obesity. You have the palm physiology, which we mentioned. Therefore, there's a need for multimodality management strategy. First, usually starting with CPAP, dental appliance. You can consider surgical treatment, positional therapy, weight loss, and bariatric surgery. You should try and actually manage your sleep hygiene, ensure they're sleeping in an optimal condition. And we do actually carry out some myofunctional therapy nowadays, and you can potentially treat the sleep apnea according to phenotypes. I will go through some of these in slight detail. So CPAP therapy, worldwide, not just in Asia and US, Europe, remains the first line for sleep apnea. Multiple masks available, but in our local population, the nasal mask and nasal pillow tend to have better compliance. Using the heated humidifier can be useful because it just reduces the dry mouth, especially in countries, temperate countries where sometimes the air does get a bit dry. And how I counsel my patients is that I do tell them that, hey, CPAP is going to be the most efficacious. When you use it, your snoring is 0, your AHI is down to less than 5, and there's really no risk compared to surgery and all. But the problem is it tends to be non-curative. A lot of people can't quite, accept the fact, and they have to wear it nightly. And it does take time for them to get used to. As I go in my sleep surgery career, I get better at treating, getting them to do CPAP, because there are a couple of tricks that we use. In a hospital, we offer them a rental, meaning, some people, if you have to buy a machine that's about $750 to $1.5K USD, it's quite a large cost, and if the patient can't use it, they just waste the money and waste the machine. So we tell them that, hey, you can try it out first and see how you feel. Don't have to commit. Even if they have to buy, I tend to tell them that, hey, you try to reframe the mindset to them and tell them that, hey, even though the machine's like 1.5K, which is crazy amount, but can last 5 to 10 years. So actually, when you divide it per month, it costs about 25 per month. And, I tend to tell them that, hey, you go out and eat one meal, sometimes 25 is gone. Okay. And we tend to try and preempt them and tell them that, hey, initially there will be some discomfort, but hey, we have a good team, we can support you. They can call our sleep tech during office hours, and we can help them troubleshoot. And I tend to tell them as well, the CPAP machine and mask designs have evolved a lot through smart designs. It can deal with almost any problems they can think of. Like, some patients say, oh, if I have a mask, I can't go to the toilet. But truth is, nowadays, there's a lot of magnetic clips where you can just detach and put it back when you want to go back to sleep. Some patients hate it where they have this tubing where it's in front of them, they can't move. But nowadays, there are tubing that, swings on top, and it's got a swiveling top, so they can turn around and the tube doesn't pull with them. Yeah. Then there's dental appliance, which I think some of you in the audience might be very familiar with as well. The whole idea is you have this dental appliance where you wear it at night, and it brings the jaw, the mandible forward. And because the airway dilator muscle, the genioglossus tongue muscle, is attached to the mandible, it is actually pulled forward. When the tongue is pulled forward, because the tongue does have attachment to the palate through the palatoglossus muscle, the soft palate can be pulled forward as well. So when the tongue and palate are pulled forward, it prevents upper airway collapse. For our unit, the better patients to refer tend to, and as per the American guideline as well, is that you refer those who fail or decline CPAP. It is more ideal for patients with mild to moderate sleep apnea and those who are non-obese. And yeah, ideally, they are also aware of the cost. When we talk about sleep apnea surgery, indications for sleep apnea surgery includes that of, you're trying to do some surgery to help initiate or facilitate CPAP usage, or you are trying to do it as a main option after the patient fails the CPAP. So what do I mean by, if you want to initiate or facilitate CPAP usage? So imagine, this is a normal CT scan, and this is a CT scan showing that the septum is bent and the turbinates are huge. But imagine if you have this sort of scan, this sort of nose, and you're trying to use the CPAP with this mask, and when you have the air blowing through, it's just terrible. It's difficult to actually breathe through. So, in fact, this has been shown in papers that meta-analysis that shows that if you actually do some nasal surgery, it actually helps reduce the CPAP pressure, and it does improve their CPAP acceptance and compliance. So common surgeries are things like septoplasty or turbinoplasty, which we can do to help the patients use CPAP a lot easier. Surgery as a treatment after CPAP failure is an option because, this is a paper, that meta-analysis that shows the outcome for multi-level upper airway soft tissue surgery. I will show you some data on maxillomandibular advancement surgery in a short while for sleep apnea. But it can work. It's better than having no therapy at all. But these are all patients who failed CPAP therapy. Surgical success, which is defined as AHI reduction of 50% or AHI of less than 20. It's not that great, but it's at 66.4%. And these are some examples. I compiled a table of the different surgeries that we can do, dividing them into volume reduction ones, where you have increase your tension or you increase your airway space. So no surgery, you can do septoplasty, sinus surgery, or nasal valve suspension. Tonsils, we tend to take out tonsils, not so much radiofrequency. Palate, you can do uvulopalatoplasty. Palatal implant seems to have gone a little bit out of favor this last many years. Epiglottis can be trimmed, or you can do epiglottoplasty. The tongue side of things, you can perform radiofrequency or lingual tonsillectomy, or you can do genoplasty, and hyoid suspension. The newer technology we have with us is the hypoglossal nerve stimulation, which seems to be quite effective. If they have global soft tissue problem, like they're overweight, you can consider bariatric surgery. And of course, the most effective in increasing airway space is your maxillomandibular advancement surgery. So apart from surgery, positional therapy can be used in patients where their sleep apnea improves in the left or right position. To help them sleep on the left or right, you can get a tennis ball t-shirt, or you can get like a medical device like the Zoma. But truth is, the whole idea of all these devices are basically to make them feel like when they lie on their back, they feel like, oh, there's something uncomfortable there. So it makes them then turn to the side. Night Balance is one that works on vibration and has very good publication from Netherlands that shows the effectiveness, as well as how it doesn't, even with vibration, it doesn't affect your sleep architecture. Yeah, but unfortunately, it's not really available. Most of parts of the world, it's not available in Singapore either. Weight loss is important to consider if the patient is overweight. Generally, you can consider medical weight loss like diet restrictions or increased activity or medication, or bariatric surgery. We do carry out myofunctional therapy. It seems to be an in thing, especially in the US nowadays. And Taiwan, Chang Gung Memorial Hospital does have a team doing it as well, which our sleep technologists went to learn from. It's basically a set of tongue and throat exercises to strengthen the upper airway tone, as simple as, having your tongue to the tip of the upper front teeth and hold it there for 10 seconds. Patients we tend to do it for are those with primary snorer or mild sleep apnea. You can use it to try and improve compliance to sleep apnea, because when you do a lot of exercise, it reduces the pressure. You can use it in patients, with mouth breathing problem. They just breathe through their mouth. It can retrain them to do nasal breathing. Yep. So this part, I'm going to talk a little bit about what I learned from Chang Gung Hospital, alternative surgery for sleep apnea. So evidence is actually better than soft tissue surgery, where surgical success for MMA, I quoted you 66% for multi-level soft tissue surgery. But for maxillomandibular advancement surgery, there is a success rate of 86, and even better, there's actually a cure rate. Cure rate means, success is 50% reduction AHI or AHI less than 20 after surgery, which actually compares the red CPAP and this 4 columns here, any form of MMA surgery associated with any other combination of surgery. You can see that MMA surgery does have generally very, very good results in AHI reduction. This 53% is trying to show you multi-level soft tissue surgery, and even worse, if you do UTP alone, AHI reduction is about 31% only. So how does MMA work? It works generally by the enlargement of your facial skeletal framework and leads to enlarged pharyngeal and hypopharyngeal airway. It basically expands your anterior, posterior, and lateral dimensions of the upper airway from the level of the hard palate to hyoid. And the lateral dimension seems to enhance more than the AP dimension, according to the Faber paper. And I think Professor Clement also has a paper in 2011 that shows the similar results. And generally, when you advance and it kind of opens up the airway space, it also really increases the tension of the pharyngeal wall, where it reduces the collapsibility. Why does it work, from the anatomical point of view, is because there are multiple muscle attachments to your maxilla and mandible bone. So for instance, the palatal muscles like the tensor palatini and levator palatini are attached to the posterior part of hard palate. So if you advance the maxilla from Le Fort surgery, this palate does advance and it actually increases your space. And the genioglossus is attached to your mandible. So when you do your BSSO, when it's advanced, it does actually increases your retroglossal space. So basically, your soft palate and tongue are advanced with the MMA, and the lateral wall tension is increased. This is the old Stanford protocol, which I think there is significant evolution from this now. In the past, they tend to recommend, hey, you do some soft tissue surgery because the rationale is it's less invasive, and then if it fails, then you do mandibular maxillar advancement surgery, which arguably nowadays, is slowly going out of favor, because the whole idea is, if you have someone with bad sleep apnea and they don't really have much soft tissue problem, they don't have large tonsils, and they have very significant skeletal framework deficiency, doing soft tissue surgery just ain't going to work. So you might as well, it's more about personalized and targeted therapy nowadays. So this is a treatment algorithm from Professor Clement Lin, my fellowship director's paper in 2019, where it tells you, it selects the patient and does more targeted treatment. So for instance, you have someone with sleep apnea, if they're overweight, consider bariatric surgery. If they're not overweight and, their modified Mallampati is not high, meaning their tongue is actually not obstructing a lot, and they have large tonsils, you can consider doing tonsillectomy and uvulopalatopharyngoplasty. But if they do have a high modified Mallampati or a Friedman tongue position, you do want to consider some form of maxillomandibular advancement surgery, and especially if they have other different features like bimax protrusion, you might want to consider segmental surgery to help a little bit more in terms of widening the airway more, as well as helping with the aesthetics. And the concept behind this, more, I think, reasonable and more advanced algorithm is that you basically are trying to treat what the problem is. So for instance, if there's soft tissue hypertrophy, yeah, by all means do your upper airway soft tissue surgery. But if there is actually a skeletal deficiency, do consider alternative surgery. And if they're obese, consider bariatric surgery. And in terms of patient selection wise, good success rate tend to happen with those with, those with skeletal deficiency. Young patients tend to do better, and those who are not obese tend to do better. One of the major takeaway points in my fellowship year that I took away was the amazing anesthesia that Chang Gung Hospital does for the patients, such that they really have a very nice surgical feel that is actually, not bloody. You can see the structures properly. So what they do is they do a nasotracheal intubation northwards, which is stitched to the nose and is stitched to the scalp to avoid any movement. And they have a sponge on the forehead to protect the patient. The patient's catheterized, and they have an art line to maintain hypotensive anesthesia, usually with a mean arterial pressure about 50. They do all sorts of protection for the patients to avoid pressure sore, because it's long surgery. Their regional and local anesthesia is the key. They do very good mandibular and maxillary nerve block with a long-acting local anesthesia. They inject along the incision line as well. If you want to know more, there's a very good paper published by Dr. Chen from Chang Gung Hospital, the same unit as well, where they actually showed that if you do your regional blocks well, you actually have less blood loss and you need less anesthetic medications as well. So this is the key part. Another key takeaway I have from Chang Gung Hospital. A lot of these are learnings from Professor Clement Lin from treating sleep apnea patients. So surgical design of sleep apnea, surgical design for alternative surgery in OSA patient basically involves maxillomandibular rotational advancement surgery. So the advancement part, it would be ideal to advance about 12 to 15 mm. Well, the conventional advancement is about 10 mm, and I prior to attending Chang Gung, honestly, I haven't really gone I haven't seen as much orthognathic surgery, but my understanding is, trying to get it to 12 to 15 mm is actually really not easy. But I will share with you some of the very learning pearls or wisdom from Professor Clement Lin in the next slide. So the reason is because if you only advance the conventional 10 mm, papers have shown that your AP dimension really improves by about 5 mm or so. So if you have someone with a very narrow posterior airway space and you advance 5 mm, the whole airway space is still less than 1 centimeter. So conventional teaching is that sleep apnea patients, you should have if you want to treat them with MMA, you should try and achieve a posterior airway space of about 1 centimeter or so for it to be effective. So one of my major takeaways from Chang Gung is, how do you actually advance 12 to 15 mm? First trick is to consider the modified Hansuk split. So you can see here, the Obergeiser split goes all the way to the posterior part of the ramus. Whereas the modified Hansuk, as shown here, it does leave behind your posterior part of the ramus untouched. So when you advance your distal segment, this gonion stays with your proximal part. The importance of it is because your medial thyroid, which is a very strong muscle, which can affect your distal segment advancement, is attached to the gonion area, as you can show here. You can see here. This is a picture showing the medial portion of the lingual portion of the mandible. You can see the attachment here. Other tricks to do with trying to get more advancement is to transect certain ligaments that actually affect the advancement of the distal segment, like your pterygomandibular ligament and your sphenomandibular ligament. And if you do somehow happen to have middle pterygoid muscle on your distal segment, it's important detach it from the distal segment, because your rotation, your counterclockwise rotation of your mandible. And if sometimes there may be necessary to resect the medial gonion from the distal segment, because when you put the distal and proximal segment together, sometimes this part can interfere with both segments coming together. Another component of the surgical design is to consider counterclockwise rotation. That's because if you actually, if you just do advancement by 12 to 15 mm, of the mandible, it will create a negative overjet. And your counterclockwise advancement can create more mandibular advancement, as shown in this picture, whilst trying to maintain a ideal or normal occlusion. And from an aesthetic point of view, if you do a straight point, straight linear sort of advancement, it does give a very protrusive appearance. Whereas if you do sort of rotation, it does have a less protrusive appearance. And I think most of the rotational point pivots around the nasion. And as mentioned earlier, especially in Asian patients, a lot of Asian patients do have bimax protrusion. Segmental MMRA can be considered, where, if you segment the leaf port of the maxilla, as shown in this picture here, what you can do is you can plan for extraction of premolar, and you bring this posterior palate forward. It does further advance your posterior nasal spine, which is here, and palatine bone, therefore increasing your posterior airway space. And from the aesthetic point of view, when you do a segmental, if they have bimax protrusion, you can actually change your proclination of your front teeth as well. So therefore, hopefully, it just makes them look not so protrusive. So yeah, come to the end of my talk. I hope I haven't overrun too much. So sleep apnea is a significant condition with multiple comorbidities. Therefore, it's important to treat. I think my learning point and learning what I learned from Chang Gung is that, for us, if you have a hammer, everything looks like a nail. So, it's important to understand other components that, you may not be that familiar. So if you're an orthognathic surgeon, understand that, there's soft tissue, you have to get, other specialties to try and help deal with, so that you can give the patient a more holistic treatment. The treatment, as I mentioned, does require multimodality surgery or strategies like CPAP surgery, positional therapy, dental appliance, myofunctional therapy, sleep hygiene, and weight loss management. Alternative surgery or maxillomandibular advancement surgery is an effective treatment for sleep apnea, and I think careful patient selection and surgical execution is the key. That's all I have. Thanks.
Okay, thank you for the nice presentation from Chu Qin. So we know that the impact of from the sleep apnea to the patient is quite large on the cardiovascular and also the metabolic aspects. And thanks for your kindly and very detailed explanation of all kinds of diagnoses from the ENT doctor's view, because we are plastic surgeons, we don't have all kinds of tools like your endoscope and or fibers and all kinds of like palate area explanation. So very good. And thanks for all the treatment management explanation, like the positional, the CPAP, and we are not very familiar with that, and also the positions and also the surgeries. And now first I want to introduce that Bo Fang also do a lot of, Dr. Bo Fang do a lot of sleep apnea surgeries with Dr. Lin. So can you give us some advice and comments on today's topic? Bo Fang with us?
Hi, can you hear me?
Yes, thanks.
Okay. Thanks to Ting for the excellent talk to give us a comprehensive view of obstructive sleep apnea. And can I just ask questions? I want to, the first thing is, I want ask to Chen to explain more about your patient selection for the home sleep study. Because in our hospital, we usually use standard PSG for these patients. And after you use home study, these patients still need standard PSG, and when they follow up for their after the treatment, they use still home study, or they have to go to PSG. This is my first question. Thank you.
Yeah, okay. I'll answer that first. I did have a slide on how to select patients for home sleep study, but I cut it off because I was worried that there's not enough time. So generally, the evidence over the last 10 years do show that, for the patients that, when they walk through the door, you kind of know they have sleep apnea. They're the fat patient, they're tired, they snore a lot, they tell you they choke, they have high blood pressure as well. Those patients, more or less, from your clinical suspicion, they already have sleep apnea. These are the ones that we select for home sleep study, because from published evidence, it shows that these patients, it's very high probability that they have moderate to severe sleep apnea. And these moderate to severe sleep apnea patients, the home sleep studies do have reasonably good accuracy. It's never going to be as good as the polysomnography, but what you get in hand is that these patients do then, get earlier diagnosis. The wait time in the hospital is 0. That means they see me today, I tell them, hey, just go across and get the home sleep study and go home and do it. Whereas in hospital sleep study, you have to wait sometimes, usually anything from 2 to 11 months. And that kind of, in that 2 to 11 months, your patients are actually still having apnea, they're still tired during the day. The selection is actually very well. Sorry, are you guys seeing my slides?
Yes.
Yeah, sorry. Give me a sec. Let me just try and get to the right slide. So the patient selection is outlined very well in this 2017 American guideline. It does tell you that, hey, home sleep study can be done in uncomplicated and those that you already perceive, as I mentioned, to have increased risk disorders like central sleep apnea, any periodic limb movements, and so on. So to just try to go through it, and if risk sleep apnea. Apologies. I think, sorry, apologies. I think my connection was problematic. Can you see my slides now yet or not?
No.
No.
Sorry. Yeah, I think my connection was a bit problematic. Sorry. Yeah. So, so to recap, how to select patients for home sleep study is very well outlined in this paper by American Sleep Study, American Sleep Medicine, where you need to choose patients with uncomplicated sleep apnea or uncomplicated conditions. So in this table, if the patient does have increased risk of moderate to severe sleep apnea, you can consider home sleep study, but that's in a background where they do not have any complicated conditions such as any heart failure, stroke, and all those things. Because home sleep study, the evidence, current evidence, they are not very validated for diagnosing patients with any of these problems. Because if you have any of these problems, you can potentially have central sleep apnea or any hypoventilation, sleep hypoventilation. So it's better off with home sleep with polysomnography. If we do a home sleep study, if it's diagnostic, meaning it does show moderate to severe sleep apnea, most of the time we do not repeat polysomnography, and you proceed with treatment either with CPAP or surgery. Yeah. But if the home sleep study is non-diagnostic, it comes back telling you that, hey, the patient does not have sleep apnea, then we don't trust it. And that's in line with the current evidence as well, where this actually suggests that if, sorry, let me just get my pointer up. So it does show that if your home sleep test is negative, you kind of really need to repeat a hospital sleep study. I hope that answers the question.
Yes, thank you very much.
Yeah.
And maybe we can invite Professor Lin. Yeah.
Okay. Yeah. Professor Lin with us?
Yes. Chu Qin, thank you very much for your presentation, because in the clinically, we usually do the skeletal surgery for most of the time, but after surgery, sometimes we see patients with difficulty to, we know that for the nasal breathing is very important for a patient with OSA, because breathing through the nose is quite important for patient to have a very stable sleep. Do you have some recommendation for patient having trouble with the restoration of nasal breathing? And what's your treatment strategy for those patients?
Thanks, Professor Lin. Just to say, good to see you here again as well. And then Dr. Po Fang as well. For the nasal breathing, sometimes we do see, even after our soft tissue surgery, like the tonsil and things, the patient still actually breathes through the mouth. And when you breathe through the mouth, the difficulty is that it gives you a very unstable airway, because when your mouth is open like that, the tongue does flop backwards and it narrows the airway. So from our side, we tend to actually treat the nose, evaluate the nose for any nasal obstruction first. If there's any nasal obstruction, we either consider some nasal steroid spray, or we can consider nasal surgery like septoplasty or turbinoplasty, which I think most orthodontic surgeons do as well. And after that, we do assess if the patient, the patient reports that they're still mouth breathing despite clearing of the nose. We do have other strategies like using myofunctional therapy to help them retrain nasal breathing, or sometimes you can use certain simple device. We do in our sleep unit, we do use certain simple device. You can just use your micropore tape and get them to tape their mouth together when they sleep. But sometimes if their jaw is too strong, we also have a chin strap that actually goes from the whole head to the chin, and it can actually work for some of the patients. So these are the strategies we have. But myofunctional therapy is the upcoming therapy thing that I think Chang Gung under Professor Yushu also does myofunctional therapy very well for this round of training as well.
Yeah, thank you. And because we sometimes we collaborate with our ENT department doctors and trying to train their mouth and the myofunctional therapy, or even use some nasal surgery. But in my personal experience, the restoration of nasal breathing is still quite difficult, especially when patient going to sleep. Probably myofunctional therapy is one thing we can try, because the positioning of the tongue, pushing the tongue forward and trying to let the patient to close the mouth. Having this type of training during the daytime could be quite helpful. I'm sorry. Oops. Okay. So this part of the treatment could be very helpful to those patients.
Yeah, I definitely agree. I think myofunctional therapy, and again, myofunctional therapy in the past seems to be a bit of voodoo, but you can see nowadays that there are actually well-published evidence with meta-analysis showing that myofunctional therapy can actually improve your snoring and can improve your in fact improve your apnea hypopnea index as well. So it's something that I think for holistic treatment, sleep units should consider. If they could actually potentially set up a myofunctional therapy service. And also another note, Professor Lin, just to update you. So our unit, we're starting to see if we can innovate and start a myofunctional therapy app that we can actually let patients do it at home. So hopefully something I can show you when it's done.
Yeah, thank you.
Thanks.
Any comments from Professor Lin?
Oh, yes, no further comments. Thank you.
Okay, thank you. So thanks for the everybody's join. So I have one question from Chen Jianzhong Yuanzhang. He also did a lot of OJ surgery on all kinds of patients, like in class 3 or probably OSA, and he is interested about, is any effect on mandibular advancement more than 15 millimeter on the inferior alveolar nerve function? What's the maximal limitations? So probably Zhu Jun or Professor Lin can give us your opinions.
I think this is a question that's better answered by Professor Clement. I just simply haven't done as much to be able to answer it. I think the question, let me recall correctly, is just that, is there any side effect if you advance the mandible more than 15 mm on the inferior alveolar nerve? Is that correct?
Yes.
Sorry, Professor Lin, bye toilet.
Usually the patient can have some sensory disturbance, and I personal experience is that probably quite the same with our ordinary orthodontic surgery, because when we do the surgery, as long as you can see the fully preservation of the nerve tract and the canal is intact, usually those patients, they don't have sensory disturbance, because basically the biggest traction force of the advancement is coming from the muscle. So when you do some release or complete detachment of the functioning muscle from our skeletal segment, then we can easily move the segment forward. And when you don't put too much force when you do the traction, and the traction force can be easily controlled and not to compromise the nerve tract or do some over traction on the nerve itself. That's my personal thoughts.
Thank you, Professor Lin. I think Professor Luo is also online. Is also online with Professor Luo 在吗？罗部长在吗？部长 yeah.
Yes. Well, actually, I do not have question to you, but I just want to congratulate you that you go back to Singapore and you establish a team, and I wish you success, and in the future we could meet more frequently after the pandemic. Thank you.
谢谢部长，谢谢部长。Thanks. Yeah, I think our team fellowship benefited a lot from Chang Gung Hospital. The Myofunctional therapy team actually started after training with Professor Peng Yushu at Chang Gung as well. So thank you very much.
Thank you for Bujang, but I also want to invite Bujang to also answer the question and share your experience on the also that question. The advancement more than 50 millimeter. Do you have any bad experience on the inferior alveolar function or any numbness after the surgery? The patient complain or they feel okay at all?
Well, in my experience, if you advance mandible a lot or setback a lot, so long as you keep the nerve intact, this kind of advancement and setback, I in my experience, do not cause further sensational problems. So I think it should be okay. But we do not have so-called evidence base to show you that advancement, how much amount setback, how much amount, is there any difference in terms of the sensation in the inferior alveolar nerve? So just personal experience.
Thank you. Thank you for Professor Luo's experience. And I think lots of people have questions want to ask Zhu for your opinion and your practice. So the first is that Dr. Reese asked, when did you use CPAP for the inpatients or the outpatients?
CPAP is usually, we do have it for inpatient and outpatient, but inpatient is if anyone needs it after surgery, then have sleep apnea. Our service does provide, but more of our CPAP are commenced as outpatient, where the patient, we have a sleep tech to support and help them troubleshoot, like if they have any problems like dry mouth or they feel the pressure is very high. So all these things, right, there are things we can do on the machine, so we can adjust the pressure on the machine. And now it's even better, they don't even have to bring their machine in for us to adjust, because new machines, CPAPs, like ResMed and Philips brand, they actually have a cloud where we can actually control things remotely. So yeah, we do both inpatient and outpatient.
Okay, and the further question is that, would you try CPAP for all the OSA patients at the start of the treatment, or you probably go directly to the soft tissue if the patient has like hypertrophy of the tongue, uvula, or palate, or go to MMA in the retrognathia patients?
Yeah, I think that's a question from Dr. Jane, one of the OMS residents. Thanks for the question. Yeah, so I still do CPAP for all patients to start with. Understanding the limit, as I grow in my sleep surgery career, I tend to find that I become better at encouraging patients to go on CPAP, for the humble reason that I feel as a sleep surgeon, sometimes there are limitations to what we can do. And especially if I only just do soft tissue surgery and the patient's not keen for MMA surgery, sometimes you wonder, the AHI I can achieve post-op may still be 20 or worse. And so I tell patients, hey, CPAP will give you a better result. So first line for myself, and to my knowledge, most of Singapore is actually still, and I think most of US and the rest of the world are still CPAP as the first line first, because we understand the limitations of what we have to offer from surgical point of view. But that's it, surgery, I do tell my patients, surgery is not evil. if they cannot tolerate CPAP and they don't foresee themselves using CPAP forever, surgery, especially like MMA surgery, in good hands, like people like doctors in Chang Gung, I think can give very good results, and it does take away the whole annoyance of having to wear something to sleep every night. Yeah.
Thank you. So, Professor Lin, I want to ask if in our department, you can share your experience about the patient go directly to us for the surgery, or you will refer the patient to the ENT for the evaluation and positional treatment, or the CPAP, or the soft tissue surgery first?
In our center, we receive referral from other specialties, such as the sleep center, the pulmonologist, the ENT, and sometimes from the psychologist. So usually they came to our clinic with proper polysomnography reports. And sometimes we do receive patients from other hospital or outside clinic, because they usually use quite different way of treatment protocol or evaluation. So we need to send them back to our sleep center to re-evaluate, to do the sleep study. And because every sleep center, the standard for the polysomnography scoring are quite a little bit different, because mainly the issue is the hypopnea. The hypopnea is scored manually by our technician, but according to different center, they have different scoring ability. So usually the hypopnea could have a big discrepancy, and usually our treatment still based on the general picture provided by the PSG. That's why, especially for patient coming for surgery, because eventually they will receive a big surgery. So we try to be more cautious, and sometimes they already did some soft tissue surgery or have some previous conventional non-surgical treatment. So they do need some very detailed examination, so we can decide what's the next step. And in our center, we try to incorporate a multidisciplinary treatment protocol, and then try to provide the general picture, the whole picture of the OSA, and then try to tell them what they should do in the following treatment steps. Because sometimes not just one surgery or just one treatment can meet the requirement or meet the needs of the patient. So we do need some detailed study, such as the polysomnography, the CT, sometimes we do some psychological evaluation, neurocognitive test to understand what's the real problem of them. Because we see a lot of patients after a certain period of OSA, they could combine with some degree of insomnia because of the sleep disturbance. They could not go into sleep, so they have the difficulty to go into sleep and not able to have their sleep last stably. So sometimes the old patient is quite complicated and complex. So we do need more study to help those patients.
Thank you. Professor Lo also has a question.
Yes, I have a question. Maybe all the specialists here, Singapore, Taiwan, can answer this question. That one thing that it's always puzzle me is that a polysomnography should be arranged for 6 months or longer. And Chu Qin also mentioned that the treatment the sleep apnea treatment will be, an average of 11 months. Why such a long time? Is it anything we can do to improve this treatment speed?
In Chang Gung, we are getting faster and faster now, probably because of the pandemic. So less patient coming for asking for PSG, and we also have a fast track for those patients. They can pay extra 600 NT, and then they can have a spatial room. That spatial room used to meet the needs for special patients, such as kids with handicap, and the number of room is quite okay. If you pay, the patient can pay extra 600 NT, and then they can have the PSG earlier. Usually within 1 to 3 months, they can have the study. Yes.
From our point of view, we in Singapore, more and more we have actually been utilizing home sleep study. We understand it's not perfect. So, one of the things that is not answered yet is, if I do a home sleep study before operation, and if I repeat a home sleep study after the operation, how good is it in measuring the change? Is it effective? Because home sleep study is for someone with moderate to high risk of sleep apnea. After surgery, they don't have that much symptoms. Can it still pick up well? So there are a lot of unknowns. We accept that it's actually not perfect, but it does help you overcome the hospital bed or sleep lab bed for the hospital sleep study. I think in the future, right? I think more for instance, now there's actually a brand called Nox, N-O-X, that actually, it's actually a pretty small one, but it does, it does wireless monitoring of your EEG. It's pretty comprehensive, almost like a level 2 study. And I think that might be towards the future, where they have comprehensive study that patients can potentially, assemble and do it themselves at home, that sort of thing. Yeah, it may be the future. We're hoping. Yeah.
Currently, some controversial between the home PSG or the full montage sleep study in the hospital is that sometimes the doctors always worry about the some data or information could be missing when you do a home PSG, because the home PSG, the channels are always less than the standard full montage sleep study. So it's always possible that the patient could be underscored if the patient is just mild or moderate, and they could be underestimated in terms of the AHI index. So if you do some treatment according to the home PSG index, then after surgery, the patient could still having some degree untreated or incomplete remission of the disease. And usually the incomplete remission of the disease could result in quickly relapse, or even the long-term outcome is not as good as when you do the complete study and then do a very comprehensive treatment. So that's the still controversial now, and people always want that maybe there's someday, because the improvement of the technology, someday we can do some home sleep study with the full montage, and the channel is not less than the hospital one, and then the patient doesn't need to have so many lines to stick to the head and everything to the nose, mouth, everything. So that's the future. But we believe that because the sensor improvement is going on, and the technology will continue to evolve, and then someday we can just sleep at home with the technology. They can tell you what's going on in your sleep.
One more questions from the audience. So our previous fellow, I think, Hondas, want to ask how many % of your children's patients finally go to the surgery after the all previous CPAP, soft tissue, and then go how much percentage? Jujin?
It's hard, yeah. So basically so basically in Singapore, right, acceptance of orthodontic surgery in our population is not as wide as in Taiwan as yet. You know, in Taiwan, you see kids, you know, going to uni, they come during the summer holidays for OGS surgery. Somehow, Singapore, the acceptance is quite hard. I would tell you which ones, I mean, about what we do is we do a drug-induced sleep endoscopy. So when I do a drug-induced sleep endoscopy and they don't have a lot of soft tissue hypertrophy, they have a lot of pharyngeal wall collapse, and that the modified Mallampati is high, I tend to MMA surgery. That out of 50, that's probably about 15 of them. But ultimate one go for surgery so far, it's about less. From my practice. I haven't come back long from Chang Gung yet. So it's very hard. Our acceptance somehow within Singapore, acceptance of orthodontic surgery is not that ready for some reasons, yeah. But there are suitable ones that the ultimate uptake is not a lot, yeah.
And for the patient that haven't done the surgery yet, probably you will try to use the myofunctional device for these patients. In your opinion, is it effective to treat the OSA patients, like patient tolerance, the effectiveness, and do the patients have long-term benefit from that? Zhu still with us?
So sure. Yeah. Can you hear? Yeah. So myofunctional therapy, most of the time from our center, the difficulty of myofunctional therapy is conceptually it sounds nice, but getting the patient to do it every day, publish papers to say, you know, it works, you need at least 30 minutes every day. So it's actually very difficult for the patient to be very compliant. In our center, we use it more as an adjunct rather than a primary treatment, unless the patient has, you know, primary snoring or they have mild sleep apnea. So, you know, usually myofunctional therapy, most of us, and right now we're more trying to explore ways to make it easier for patients to do the therapy at home by creating an app. But at the moment, compliance is an issue overseas, all over the world. In the US, the way they do it is that they have myofunctional therapists, like they go to the office to see the therapist for this sort of therapy. And, you know, it's actually very labor intensive and it's very costly. So yeah, at this moment in time, if you look at available evidence as well, we don't tend to use it that much for any moderate to severe sleep apnea patients. It tends more, at least in our center, it tends more to be as an adjunct.
Okay, so as we know that obesity is one of the contribution factor to the OSA patients, so would you like to suggest patients or refer them to the metabolic doctors or the general surgeons for bariatric surgery before your like surgery, soft tissue surgeries or the OSA surgeries? How is your what is your cut point for the BMI for these patients for the further treatment?
So our hospital has quite clear guideline from the bariatric surgeons. If their BMI is more than 27 and they have comorbidities, meaning diabetes, high blood pressure, any of this metabolic syndrome, or they have diagnosed sleep apnea, they can consider bariatric surgery already. In general, in my clinic, if they're overweight, I tend to push them more for CPAP. Even if they have large tonsils, I'll take out the tonsils, but I tell them that, hey, even if I take out all these things, or if we consider like MMA surgery, the fat within the tongue and the pharynx is just still not gonna make the sleep apnea go away. So these patients tend to, really work very hard to help them to get on CPAP.
Okay, and so probably due to the time limit, we have one last question from the Reese. He asked that twin block appliance and the mandibular advancement device, which one can help for OSA effectiveness?
Okay, I'm not an orthodontist, so usually these sort of thing I actually usually it's done with orthodontists. Usually for mandibular advancement device, there's twin block and monoblock. But my limited understanding, twin block is a little bit more effective. And based on the American guidelines about using dental appliance for sleep apnea, you do need to consider customizing the patient for it. It can be very effective for mild to moderate sleep apnea. It has been shown to reduce AHI and improve sleep quality, as effective as CPAP in mild to moderate sleep apnea with better tolerability, but not so much if the patient's obese or they have moderate sleep apnea. Yep. Anyway, also just a big shout out to my fellows, Elkie and Ivy. Thanks for attending.
Thank you for the nice presentation and complete picture from the OSA diagnosis, treatments, and all these treatment algorithms. And thanks for the our best faculty staffs from the CGMH as today's panelists. And thanks for all the very nice questions from the audience. So at that last moment, I want to give back to the Dr. Zhou Baoyun for the final remark. Zhou Baoyun,
okay. Yeah, thank you. Thank you very much, Jiafang, for your very nice moderation for this presentation by Chu Qin. Thank you, Chu Qin. You have a very great presentation for all of us. And I thought a lot of the same years fellow Ivy and Aoki, and say the congratulations and express their appreciation for your talk a lot. We learned a lot from you as well, from your very comprehensive talk, very organized, teach us how to treat and to differentiate different methods to treat the patient with the OSA. Finally, I think that we could have a group photo together, okay, in memory of your very valuable presentation. Yeah, even though I don't think the signal is good in Singapore.
Sorry.
It's okay. Yeah, but I think we all understand what you want to express. Okay, we saw a lot of very valuable our teachers here with us. So I will count to 3 and let's us to have a group photo, okay? So come on, show up. Yeah, thank you, Abby. Thank you, Aoki. Thank you, remain here with us. Okay, 1, 2, cheese. Okay, could you give me one more? Yes. The next one, and probably you can give me a spatial gesture or some sign. Yeah. 1, 2, okay, cheese. Okay, thank you very much for your participation in this very great night and or in the evening time in your side. So finally, I will introduce our next webinar. The next webinar is the next Sunday, and will be presented by Dr. Rami Halak. And Dr. Halak is Associate Professor in Dallas Children's Hospital. The topic he wants to present is the artificial intelligence in the diagnosis and the treatment of the craniofacial anomaly. So it's kind of a bit of a technical issue. Yeah, so welcome all of you will come join this webinar 7 days later. So thank you very much again for Chu Qin's great talk tonight with us. And I have to say thank you, bye-bye, and have a nice day or have a nice evening. Thank you very much.
Thank you.
Thank you, Chu Qin.
Thanks,
Thank you,
thanks.
Chu Qin.
Bye. We'll see you around.
Yeah.
Bye.
Bye-bye.
Bye,
Bye bye. See you again.
Bye. Bye, Huike. Bye, 播放学姐.
Bye bye.
Bye, Ivy. Bye, Elkie.
Yeah.
The connection wasn't.
Yeah, we can disconnect. Okay, have a
Oh.
good night, Chu Qin. Thank you
Thanks,
very much.
thanks.
Yeah. Thank you, Professor Clementine. Bye-bye.